everyone, this is Dr. Aliyah Baluch. I'm one of the infectious disease attendees at Moffitt Cancer Center. Today we'll be discussing kind of a general introduction topic to infections in cancer patients. I have no conflicts of interest other than the fact that I also use Apple products, which you'll see that pop up, but they're just because that's what I have access to. Goals and objectives for today is to review infectious disease definitions, epidemiology of infections in cancer patients, defining high versus low risk neutropenic fever, a couple key things about monoclonal antibodies versus ID issues, antimicrobial stewardship, as well as review some selected infectious syndromes. Our resources, what we use to make lectures like this, as well as to guide our clinical practice, IDSA guidelines. This was the most recent one pulled from the IDSA website from 2010. ASCO guidelines, also in reference to neutropenic fever in adults. The Stanford guide, which now I recommend for everybody to have on their phones because they're constantly being updated, whereas the book is only updated once a year. Lexicom is very good for drug dose adjustment, especially for kidney function issues, and NCCN guidelines for all things related to cancer and infections. So basic things is what you need to have before you can make a decision about what drugs for what bugs. So fever, there are two different definitions per IDSA. One is a single temperature versus a sustained temperature over an hour. Single temperature of 38.3 or 101 degrees Fahrenheit versus a sustained temperature more than 38 degrees or 100.4. These are very important. We actually had to reteach our nurses the bone marrow transplant unit at my primary hospital it wasn't just at the first fever of 100.4, but to please recheck it after 1 hour. If it is sustained, then you call the attending on call to start neutropenic fever protocol. Neutropenia is considered to be a neutrophil count less than blank within 24 hours, and it is 0.5 or 500 cells per millimeter cubed. Whenever you look at IDSA guidelines, especially, they're rated between strength of recommendation, A being the best, quality of evidence, 1 being best. So with this in mind, then you look at factors affecting your infectious risk. There are host factors, there are drugs affecting your host, and recent procedures. So diseases are a big issue with host factors, whether it be CLL or multiple myeloma. These are two key things that you see repeatedly. Drugs, steroids creating an overall decrease in your immune system, monoclonal antibodies which will selectively kill a certain subset of cells, antibiotic exposure notoriously being, for example, clindamycin and fluoroquinolones increasing your risk for C. diff associated diarrhea. Recent procedures in the setting of cancer patients, a tunnel catheter like a Hickman placement. In terms of general exposures, for example, a cardiac patient who's gone for a catheterization procedure and has a rather large divot in their growing area. This is just a graphic talking about the interplay between underlying disease, chemotherapy, iatrogenic manipulation leading to your risk factors for infection. A different perspective is looking at heme malignancies and MDS. Why do you have neutropenia? Whether it is because you've been pounding the bone marrow with chemotherapy, or there's actually disease of the bone marrow not allowing for any new cells to go out. Or what about hypogammaglobulinemia? So the diseases that notoriously cause this, CLL, multiple myeloma, a splenectomy. You have to be careful though. Even if the number looks good in your amount of immunoglobulins, understand that oftentimes the quality is poor, so then overall you don't have the immunoglobulins and you're still at increased risk for encapsulated organisms like Haemophilus influenza or strep pneumoniae. Looking at is all chemotherapy-induced neutropenia and risk for fever made equally, and it's not. In solid tumors that have neutropenia, 10 to 50% of your patients will have fever. You compare that to hematologic malignancies, of which more than 80% of them have fever, hence the reason why more of them are on the inpatient service. If a patient asks you on rounds, well, what's the chances that all these cultures, blood, urine, and imaging, is going to actually find an infection? You can say that actually up to 30% is our maximum that we're going to get an actual organism. That doesn't mean there's not an organism. Either it's below the level of detection with our current standard of blood cultures and urine cultures, or they're having SIRS, for example, because of mucositis due to chemotherapy. So, what about risk stratification for neutropenia fever? When do you do it? When you get that phone call or when you see that patient that has neutropenia fever, that's when you make the risk stratification. Why is this so important? Well, you got to figure out if the patient's calling you from home and you're a hemonc fellow or you're the ID fellow that is getting called and you're like, does this patient need to be admitted? And you look, you should be able to risk stratify in your brain. Well, do they have risk factors? Can they be outpatient? Do they need to be inpatient? Can they take oral medicines or do they need IV medicines? The easy example is if your patient's on TPM because they can't eat, they're not a candidate for oral medications. So there actually, IDSA has a comparison of low risk factors for neutropenia fever versus high risk factor. Low risk is neutropenia deemed to be less than 7 days, no or few comorbidities, and that they are a candidate for oral antibodies. Conversely, a high-risk patient is neutropenia expected to be more than 7 days, profound neutropenia being less than 100, significant comorbidities at the time of your initial phone call being hypotension, pneumonia, altered mental status, and they have to be admitted. What about your initial workup? CBC with diff, CMP, very important. You should get minimum of 2 sets of blood cultures. So, for example, if you have a Hickman with 3 lumens, you get a blood culture from each lumen plus 1 peripheral. If you have no lines, you get 2 peripherals. And then, obviously, if you have symptoms in a particular place, whether it's your eyes, your nose, GU tract, you get specimens from those sites. If a patient has respiratory symptoms, you get a chest x-ray. What about the bugs that we're trying to think of? So, for example, in the 1960s to 1980s, the organism that was mainly causing problems was what? Mainly aerobic gram-negative rods like Pseudomonas. Then you flip it over to the mid-1980s, what organism is here? And actually it's like a pendulum that was swinging. It became gram-positive cocci, for example, coag-negative staph and Staph aureus. You could ask, well, what happened? Why did this transition occur? There was quite a significant change in chemotherapy style. It became more, what I would call, from an ID perspective, aggressive. There was more mucositis, leading to an increased risk of translocation of organisms from the mouth and GI tract. Patients were being neutropenic longer. We were using more indwelling catheters like Hickman's, use of H2 antagonists, and antibiotic pressure with antibodies with little gram-positive coverage. For example, if you can imagine you have a flat plane, which is your microbiome. You smush it down in the center with the Cipro, and then it rises on either sides, therefore selecting out bugs that are resistant to Cipro or can grow past ciprofloxacin. What about 2010 onwards? The pendulum started to swing again back towards center. You still have your coag-negative staph because we're still using a lot of Hickmans, but you have your reemergence of gram-negative organisms, unfortunately tending to be more drug-resistant. This is just a snippet from the IDSA guideline talking about common gram-positive pathogens, like I mentioned, coag-negative staph, Staph aureus, the Enterococcus, strep viridans coming from the mouth, strep pneumoniae, strep pyogenes, and multiple gram-negatives, of which I want to put a special notation for stenotrophomonas. That stenotrophomonas is a big issue for patients that have been on carbapenems before. So if a patient is getting admitted and they're high risk, obviously, hence the reason for admission, the coverage needed for Pseudomonas, you have a choice of different antibiotics. You have anti-Pseudomonal cephalosporins like cefepime, meropenem, piptazo, also known as Zosyn. If they have hypotension at the time of admission, you have to think of additional coverage, like do they need an aminoglycoside for gram-negative coverage? Are they at risk for pneumonia or multi-drug resistance? But do note that it is not standard care anymore for all patients to get IV vancomycin up front for their initial workup of neutropenic fever, unless at the time of admission you see that there's a notation of cellulitis or a catheter-related infection for which that's the cause for the vancomycin need. On that same note, there are special times if a patient has a history of every time they have neutropenic fever, they have issues with MRSA, you give them vancomycin, linezolid, or dapto to cover for their MRSA infection. If they have a history of VRE, for example, perirectal abscess, every time they have neutropenic fever, you can consider the early use of linezolid and dapto, understanding for every drug you add, you also add their potential side effects. If a patient has a history of ESBL infection, consider early use of a carbapenem like your meropenem instead of trying to use cefepime or piptazo. If there's a history of KPC infection, you need to consider early use of polymyxin, colistin, and tigecycline. But in all honesty, you really need to be consulting infectious diseases at that point because these patients get very sick very fast and using these drugs becomes very complicated. If a patient has an allergy to penicillin labeled on their chart, you have to actually go and assess the patient, discuss with them what kind of allergy are we talking about. Were you a child? Was it a rash? Was it that you had a viral infection followed by a rash? Because the rash could have been more from the viral infection, not from the antibiotics. Oftentimes, you grow out of childhood allergies. The issue, though, is if they describe anything related to anaphylaxis, like they stopped breathing or they required ICU visit, these are real penicillin allergies and not worth the risk of re-exposure. Most of our patients who just have an allergy of quote-unquote rash when they were a child, we discuss it with the patient, we make sure the patient is willing to retry, and then we retry them with the cefepime because we have the ability to monitor them with our nurses on the inpatient service looking for whether or not they get drug rash. If they do have a true allergy with a history of anaphylaxis, you give them a monobactam drug like aztreonam plus the vancomycin because aztreonam has no gram-positive coverage. So that way you fill in that hole in coverage with the vancomycin because of the concern for gram-positives from the mouth. If the patient is stable, has less than 7 days of neutropenia expected, then you can give them cipralenamox clav for their outpatient neutropenic fever. What happens if they were sick enough and you had a history of a need for gram-positive coverage and you gave them vancomycin or dapto? If the workup is negative, in 48 hours you get rid of the gram-positive coverage. This is an A2 indication. On the other side, if the patient is still worsening after your initial choice of antibiotics, ideally, after a couple doses, making sure you're at sufficient level of the drug in their system, you may need to broaden your coverage for resistant organisms, anaerobes, and or fungi. There's a couple key things that have come up in the recent literature with this change in chemotherapy, and then one of them is this translocation of strep viridans. So strep viridans has multiple different organisms that makes the group that you might see in your local micro lab spit out, whether it be Streptococcus mitis, oralis, salivarius, milleri. These all are considered strep viridans. It comes from your mouth, translocates while you're neutropenic and with mucositis. 90%, this is a simple scenario. You have fever and bacteremia, you treat them appropriately, you start them with vancomycin. When you get your sensitivities, you try to narrow if possible. The problem is the 10%. The 10%, they actually present with a toxic shock-like syndrome and possible acute respiratory distress syndrome. These are the ones that go downstairs to the ICU, have a mortality up to 30%. Some persons try to use steroids to calm down the lungs so they don't end up intubated. Increasing issues with antibiotic resistance. When you actually look at the sensitivities of the organism, you first look for levaquin sensitivity. If the levaquin is resistant, then you look for ceftriaxone sensitivity, and then you go up from there. The risk factors being the cytosine arabinoside usage, H2 receptor antagonists. What about a couple organism keynotes? In terms of Candida, this is especially needed for prophylaxis against invasive candidal infections. So this would be your patients in salvage induction chemotherapy for acute leukemia. This is also needed in allogenic hematopoietic stem cells. So fluconazole, triozoles like your posaconazole and voriconazole, and echinocandins. The issue with using triozoles in allogenic stem cell transplant is the known drug-drug interactions with the immunosuppression like sirolimus and tacrolimus. So you just have to follow your levels. If not, some programs might use echinocandins like mycofungin because they're quote-unquote cleaner and you don't have to do the drug-drug interaction adjustments. In terms of aspergillus infection prophylaxis, so it's indicated for those that are neutropenic with a prior history of invasive aspergillosis, because we know bugs that you had the last time you were neutropenic tend to come again when we make you neutropenic a second time. Also, if you're neutropenic for more than 2 weeks, it is a C3 indication that you're at increased risk for mold, so then you need a mold antifungal type of drug. If you're prolonged neutropenia trying to go into an allo transplant, we try to keep you as healthy as possible. You're also at indication for using anti-mold prophylaxis. What about monoclonal antibodies? There's been increasing number of indications for using antibodies in multiple different types of case scenarios, but keeping our eye on the last 3 options, I just want to say a couple words about these drugs. Rituximab and ustikinumab, they're both CD20 drugs. Rituximab for our patient population where I work a lot, used for post-transplant lymphoproliferative disease. Ustikinumab has been used for graft versus host disease. Key thing is they're both anti-CD20 drugs. They deplete the B lymphocytes, therefore you have less plasma cells. This is the type of cell that makes antibodies. So not only do we knock off part of our immune system, you cannot make vaccine responses, creates quite a huge defect in our immune system. The key thing to understand from this slide is, though from a bone marrow transplant perspective, they'll tell you, oh, but the ustikinumab only has an effect for 6 months. That might be only 6 months for GVHD prophylaxis, but it's more like about a year from a perspective as an immunosuppressor and decreased antibody production from an ID perspective. What kind of bugs are at risk for monoclonal antibodies? Oftentimes intracellular organisms, mycobacterium, hence the indication to get TB tested prior to receiving a monoclonal antibody. Listeria risk, Legionella, endemic fungus, where especially histoplasmosis and in general they're at risk for dissemination at the time of presentation, and also for hepatitis B reactivation, much more so than hep C. A word about alemtuzumab in the center of this graphic, often used for different types of, actually is used in the rheumatological era as well as from the heme side. The main thing I just wanted to mention was here you have a drug and it has its own individual risk for pneumocystis jirovecii reactivation. So the idea being, if you use alemtuzumab or Campath, that increased risk for additional 2 months or until CD4 count greater than 200 for PJP. What about a couple words about BMT and our use of stewardship? So in 2013, we did 450 bone marrow transplants. They come in multiple different flavors. The average duration of neutropenia is shorter than in the majority of our acute myelogenous leukemia regimens, which allows for a different risk stratification for organisms. Here is a very nice graphic based on time post day 0, the day you get your cells, and your risk for different infections. Looking here in the beginning, in the pre-engraftment phase 1, the organisms you see, these dictate our prophylaxis. Cipro, our antifungal, which could be in multiple different flavors, and acyclovir versus HSV, and then following up VZV. So, knowing that stewardship requires 3 big arms: your detection of your bugs in as timely as a manner as possible, your prevention of emergence of antimicrobial resistant organisms and appropriate use of antibodies, and controlling outbreaks and isolating patients adequately. As this was just giving a snippet, we will only look at this prevention type of aspect right now. So, how do you select? What are the questions that come up for optimal selection of antimicrobial regimen? We're looking at dose, duration, and route of administration. If a patient is eating, walking, talking, Levaquin IV is inappropriate for this patient, whereas Levaquin PO would be the correct route of administration. Why is this important? It promotes the best practice, best clinical outcome with the least toxicity or adverse effect, ideally leading to less antibiotic resistance, less bystander infections like C. difficile. How is the U.S. implementing antimicrobial stewardship? Well, unlike in the UK and Canada, long-standing relationship with stewardship is not required in the U.S. There's only one state that has a mandate at this time for stewardship. California Department of Public Health via Senate Bill 739 requires that all general acute care hospitals have a process to evaluate the use of antimicrobials. I suspect this will be ongoing. The VA already also has a mandate, and because of the use of antibodies and trying to get you look not just at one patient at one point in time, to look at that patient over the continuum of their life, as well as your ward, as well as your hospital, and then even on a national level, because it is an international issue. For us on bone marrow transplant, we're trying to look ahead at Europe. They are being very aggressive with their de-escalation of antibodies after 72 hours or later in neutropenic patients that had fever but are stable and afebrile irregardless of their neutrophil count. We're not as aggressive as 72 hours, but we're looking at doing this after 5 days of negative workup to bring them back down. With this in mind, as well as the implementation of our SMART team, which is our stewardship team at my local hospital, you can see we've had an overall decrease of carbapenem use, especially being meropenem, because that's our carbapenem of choice. There's always going to be a certain amount of aztreonam required for patients that have a true anaphylactic type penicillin allergy. Looking just at the first section for our bone marrow transplant patients, we also severely decreased our meropenem use. Again, there's always going to be a certain percentage of patients that requires meropenem for a cause, being a history of ESBL or a bug that just is not clearing correctly. And understand that a DOT is that for whether or not your drug is given once a day, twice a day, or 5 times a day, that one patient gets 1 dot. And that's how this is counted for stewardship. Looking overall, well, what happens to the other drugs? You're going to have a certain amount of cefepime, but it should plateau because this is your go-to drug at my facility for neutropenic fever. Meropenem should also decrease, then plateau, but there will be a certain number of patients who require piptazo because maybe of the anaerobic coverage or a non-tolerance to cefepime. Then what about gram-positive coverage? IDSA is pushing more and more, saying that you don't need it as standard for neutropenic fever. Only use it for cause. So we see daptomycin and linezolid use go down. And then looking specifically at the first section for bone marrow transplant, you can see definitely our amount of daptomycin is decreased such that there are even some months without daptomycin use. But then you could ask me, well, why do you have so much vancomycin? Well, For bone marrow transplant at my facility, we use tunnel catheters like Hickman's, so they often get cellulitis, so then they require vancomycin while they're neutropenic for their transplant. With that in mind, this type of counting, the DOT per 1,000, cannot tell the difference between using vancomycin for bacteremia versus vancomycin for cellulitis. So this is more reflective of the fact that I use it to treat cellulitis. Couple selected syndromes here. First one is a 71-year-old with history for MDS. He got a match unrelated donor allogeneic stem cell transplant in January 2013. He had engrafted, he had gotten discharged, he was only on acyclovir. He has a variety of different things in the past, but I do want to point out that patient has chronic GVHD of the skin, for which he's on extracorporeal photopheresis. He got short of breath and had a CT scan. This is his old one, this is his new one. Here are some cavitary nodules, a large nodule here, and subsequently here as well, and then with some areas of ground glass. So we described the CT's new onset nodular pneumonia, possible causes, what is the next step. So we sent him for a bronch. He grew out Homographiella species, and you scratch your head and you're like, what is that? So you look and you're like, it's a fungus. You then do some literature, you're like, fatal, never good. Here's another fatal, also not so good. So what were the key things from the article is that you couldn't use echinocandins, the patient is overly immunosuppressed due to his GVHD treatment, and that you should treat with amphotericin products. We use Ambisome. I started the Ambisome. I got a text followed by a picture. Note that this is his port, this is his chest. When I push on this rash, it does not blanch. So he had petechial findings within the first 5 minutes. He had no pain, whether in his back or his chest, no fevers or rigors. What do you do? What do you ultimately do? So a couple words about Ambisome. Ambisome is a vesicular bilayer liposomal version of amphotericin. The range of the dose is 3 to 5 mg per kg. You're supposed to infuse it slowly. The adverse effects are rigors, nephrotoxicity, hypomagnesemia, rash, which traditionally not described like this, flushing, urticaria, but usually at the end of the visit. So the decision after speaking with my team, pharmacy, the BMT team, that we definitely had a nodular pneumonia that was significant. We had an organism and highly immunosuppressed that could not be adjusted. So he understood the risks, and so we tried the other type of amphotericin, and actually he was able to tolerate the entire 3-month course, but we did pre-medicate him such that I made him mildly cushingoid. You can see his follow-up CT scans, all the nodules resolved after the standard 3 months of treatment. Just a few words about large nodules. If the patient just came off the street, you would have to be concerned for malignancy. In terms of infectious etiology, about 90% are molds, 5% nocardia, 5% boop, and then a variety of other ones, but those tend to be smaller nodules, not so much larger. A few words on the molds that are my favorite: Aspergillus, Zygo, and Fusarium. Aspergillus and Zygo tend to be larger nodules. Fusarium tends to be smaller because of the way it gets there, being hematogenous. Aspergillus comes in many flavors. Oftentimes, though, when you work too often at my hospital, you would think it's only the last, but actually there are many. In terms of the invasive, remembering that it's acute angle septate, you have fruiting bodies, it can have lung, sinus, skin, or CNS. The plate can often have the green furry look. Here are your septated angles. Here's your fruiting body. Here's a large nodule. Here's your also cavitary lesion with a halo. In terms of Fusarium, most often seen Fusarium solani because it tends to be more drug resistant. The key phrase to remember is banana-shaped macroconidia. It can create superficial, local infections. Your risk factors are steroids, neutropenia, T-cell depletion, GVHD can cause it. This is your main one that if you're going to have a positive blood culture from mold, it can be your Fusarium. Often starts with a toenail infection that goes into the soft tissue. It grows nicely, relatively nicely on the plate. Here, if you just had this picture, you really couldn't tell the difference between this and aspergillus, but here's your banana-shaped macroconidia that is stereotypical for fusarium. Here, because it's hematogenous, you have your small nodules that have been sprayed onto your CT of your chest. In terms of zygo, remember that has many different species within it: Absidia, Cunninghamella, Mucor, and Rhizopus. This is your non-septate hyphae, 90-degree angles, moose antlers or ribbon-like. Again, neutropenia, steroid use, DKA, iron overload, and you may have your reverse halo. Here's your microscopy. Here's your fruiting body for Cunninghamella. Here is a CT scan that became grossly abnormal, 4 days of neutropenia, but the patient had been grossly pre-treated with steroids prior to coming in for his transplant. This is just an image of the Sanford in the phone. That aspergillus, for example, voriconazole is your drug of choice, whereas for fusarium, your drug of choice is amphotericin products, and that for Mucor, also your drug of choice is amphotericin products. What about small nodules? It's all about going in the blood and then splattering onto the chest. So fusarium, pseudosporium, fusobacterium, staph aureus, or rapidly growing mycobacterium. What about one skin scenario here? I had a 55-year-old who had multiple myeloma, status post in auto. We got consulted for sepsis and rash. Patient was pancytopenic, neutropenia day number 4. Did have fevers of 102, but no infectious history prior to the auto. Relatively healthy, other than her multiple myeloma. This is in her inframammary area. So note that actually the rash I'm pointing to is just this area here, this area here, this area here. She has nystatin powder, as well as someone demarcated with a black pen around the area. She also has some circumferential erythema. So this type of rash, black spot, is ecthyma gangrenosum. You have to worry about the aggressive gram-negatives like Pseudomonas steno and the aggressive gram-positives like Streptococcus pyogenes, Staph aureus. Lesions in the groin, thigh, and under the breast. If you culture the wound, it tends to grow the same organism as in the blood. The patient was actually septic with Pseudomonas, treated with cefepime, as that's our go-to drug. The BMT team asked for voriconazole for mold coverage. We say like, oh, maybe the black spot is for mold. Why is this necessary or not necessary? It goes back to risk stratification. Patient was only neutropenia 4 days, had none of the risk factors for mold, not neutropenia more than 14 days, or items like that. So we didn't give any vori. We just treated with the cefepime. A couple words about photosynthesizing antimicrobials. Come in multiple flavors, but you have to actually educate your patient about staying away from the light, use some protection. A lot of these drugs are very common: tetracyclines, fluoroquinolones, sulfonamides, and voriconazole. This is a picture taken from Dr. Green. You can definitely tell where the patient had a shirt on, and then the areas where the shirt wasn't covering, he had a photosensitizing rash. So we reviewed some pertinent infectious disease definitions, the epidemiology of infections in cancer patients, high versus low risk neutropenic fever, specific issues with monoclonal antibodies, some key elements of stewardship at my local facility, and reviewed a couple selected infectious disease syndromes. I would like to thank multiple patients that we have all the time at Moffitt, the staff at Moffitt, and SMART, which is our stewardship group, infection prevention microbiology lab, pharmacists, and physicians. This is when we celebrated our 5,000th transplant, and the SMART team. In terms of references, I detailed them at the bottom when I spoke about them, but here they are as well. Thank you for your time.